All right. I welcome you to this second section. We're still discussing on PMTCT and the intervention and the strategy. In the last session, we gave a general introduction about the concept of PMTCT, and we went forward to look at the key components of HIV prevention. Then we also looked at the key components. One of the key components of PMTCT, which is initiation of the antiretroviral therapy, and under which we looked at the pre-test information. We are going to inform the woman about PMTCT, the chances of transmission of the virus to the infant, and the chances of not transmitting it in either ways if they use the program or if they don't use the program. So in this section, we'll be looking at the information you're going to be telling this woman for them to either subscribe or not to subscribe, because it all depends on how you told them, what you told them, and how you presented it. You have to explain the testing procedure, whether you're going to use needle prick to take their blood sample or take through the vein, which is usually recommended for, because what you practice at primary healthcare level is mostly screening. For higher tests, the blood sample, you have to take enough blood sample so that other tests can also be run with it, except where the lab decide to have their own sample anyway. They have to explain that the test result will remain confidential because they will be scared. Should in case this is HIV positive, how would they feel? You have to reassure them that the test results, whether negative or positive, will always be what? Confidential. Then you have to explain that they can refuse the test, but if they change their mind, they can take it during any time of their visit. But also let them know that if they don't know their status and they had HIV positive, that the chances of transmission is higher. But if they know and PMTC strategies is given, which include initiation of the antiretroviral, the chances of transmission of the virus to their unborn is less than 5%. Now, if the woman has tested negative, you have to explain the meaning of that negative HIV test result and the importance of remaining HIV negative. If it doesn't have the virus, you have to, yeah, this result shows that you don't have it. And you must try as much as possible not to get this virus by practicing safer steps. Then you have to rediscuss method of prevention HIV, which you have already explained to her. You don't have to really explain to her. You don't have to really explain to her the meaning of that positive result and how HIV can be contracted. You have to discuss risky behaviors such as oral sex, multiple sex partners, multiple sex partners without protection. You have to discuss risky behaviors and the need for protection, particularly during pregnancy and postpartum. You have to encourage the woman to return to take a test again in 3 months or before delivery. In case when you tested her, he or she was in the window period, in 3 months' time, you need to redo another one. During that point, encourage her to bring her partner for testing too. Now, you have to give this woman condoms at each ANC visit. If the woman has tested positive, you have to explain the positive result and also provide emotional support to this woman. You have to explain that she has a good chances of staying healthy and also healthy and well for a very long time. And also that her child has a good chances of not being HIV. So you have to explain to her that her child has a higher chances of becoming negative if they continue to come to the clinic and to follow the advice you're going to give. And that advice is part of PMTCT. You also have to explain the risk of HIV transmission to the child if they don't accept or subscribe to that PMTCT strategy. You have to explain the PMTCT intervention, telling them about ART for her own health, for prevention of the virus transmission to the child during delivery. Then you have to explain the importance of regular follow-up before and after they are giving birth. Then ask her if she has other children. If she has other children, you have to discuss of her on how to bring the children so that they can be tested too. Then encourage her to bring her partner for testing too. So these are information you must offer to this woman. Now, under PNTT, like the first component we're looking at the initiation of ART. We have looked at a pre-test information. We look at pre-test information, what you're going to tell her, the mode of HIV transmission, the importance of PMTCT, the chance of getting a virus without PMTCT and with PMTCT. Then, what HIV virus is all about. Then, post-test information. After you've tested the person, if negative, the information you're going to provide, which we've discussed. If the person tested positive, the information you're going to provide if the person tested positive. Now, we are looking at a HIV positive person who have tested positive. Now, it's starting ART early. When antiretroviral therapy is started early, it allows enough time for the mother to reach an undetectable viral load before the high-risk period of MTCT, which is the point of transmission. That is mother-to-child transmission. And that high-risk period is usually late pregnancy. Late pregnancy, during labor, delivery, and few days following delivery. These are called high-risk period because this is the point when mother circulation can have contact with that of the fetus because the baby will pass through the birth canal. The protective structures, the placenta, the membranes that protect the baby while the baby was in utero will break. And when this breaks, the baby is now exposed to maternal blood and fluid. As such, it's a very high risk period. So the late pregnancy, labor, delivery, and immediate postpartum period when the baby is being breastfed are usually critical times. So if the HIV is identified early in the mother and treatment is started, this period, the viral load will be very low that it may not be able to transfer to the baby. So therefore, it significantly reduces the risk of what? Transmission. When ART is started early, it decreases the mortality among HIV exposed but uninfected infants and have good impact on the survival of the mother. Preparation and counseling section. You have to prepare and give a serious counseling to this HIV mother whom you want to start this ART for. Before the ART is started, the pregnant woman should be retested again. This retest should be carried out on a new sample and ideally performed by a different operator. But you have done your own. It's also good to refer to lab. Take that same sample, or the person might collect another sample again from the mother. Okay? To actually check. However, if no other operator or lab is available, this should not delay the initiation of ART. Then you have to cancel the mother. So what is the talking about that? Once you have screened and it's positive, start the ART while referring the mother for further text. before you start the drug, you have to cancel because there's high rate. So it's really important that you cancel the murder before proceeding. ART should be initiated as soon as possible in all HIV pregnant women, both those that are breastfeeding, regardless of the WHO clinical stage or CD4 count. And this ART should continue for life. And this will continue to all the days of the person's life. Based on some protocols, each country has their own protocol on how these drugs are being prescribed. So the current regimen for choice for all pregnant or breastfeeding mother is the same as for any adults. So it is the same drugs that are given to adults that you give to pregnant women. A fixed dose combination known as FDC, fixed dose combination of tenofovir, lamivudine, and dolutegravir are given. One tablet once daily. So that's the pill. Okay, tenofovir, lamivudine, dolutegravir are all given as one drug. There are 3 drugs to one. Known as fixed dose combination. Is given once daily. Then there is also a regimen of choice for pregnant and breastfeeding mothers who also have tuberculosis, TB. An additional dose of DTG, about 50 milligrams, 12 hourly after that dose combination. What is trying to explain for that women also who have HIV who having tuberculosis, you give them the fixed dose combination of the tenofovir, lamivudine, and dolutegravir. I don't know the pronunciation. So when you give them this fixed dose combination, you also give them additional DTG 50 milligram. That's the dolutegravir. Additional 50 milligrams, 12 hourly after you have given them that fixed dose combination. That is for women who have tuberculosis. You should ideally check for creatinine clearance prior to initiation of the TDF. That is tenofovir, all of that. You have to take the creatinine. The creatinine has to do with kidney. If their creatinine level is less than 50 ml per minute, then zidofudine and lamivudine should be used. If their HB is less than, that is the hemoglobin is less than 8 grams per dl, or you use abacavir and lamivudine. Use abacavir and lamivudine. So what we're trying to say here is that the fixed dose combination is tenofovir, lamivudine, and dolutegravir. That's what is given for every adult. That's what you start the pregnant women on. But if they're pregnant women who is HIV positive, also have tuberculosis, you will have to be given 50 milligrams, 12 hourly of DTG, and DTG is dolutegravir. But however, if the person have kidney issue where the creatinine level or creatinine clearance is low, you should give zidofudine and lamivudine fixed dose combination, or you give abacavir and lamivudine combination. Why is it important that you check the creatinine clearance before you start initiation of tenofovir? Is because I think the drug has some effects. I don't know on the kidney, but I'm thinking. So, but the protocol says you should be able to take the creatinine clearance. And this is done by lab people. So you have to send the patient to the lab for this assessment. Another component of PMTCT is safe delivery practices. We have initiated drugs in the fixed-dose combination of tenofovir, lamivudine, and all of that, or to use of the other combination if the creatinine clearance is poor. Now we are into safe delivery practices, which are a key component of PMTCT. It says that vaginal delivery is usually safe for women with undetectable viral load. So if we start these drugs on time, like we said, it will reduce the viral load to minimal during the high-risk period, which is late pregnancy, delivery, and postpartum. So if their viral load is undetectable, they can go ahead and deliver their baby through their vagina. But however, if the mother has high viral load at the time of late pregnancy or delivery, cesarean section is usually recommended to avoid transmission of that HIV virus to the baby. So while carrying out, let's say the mother has an undetectable level, it's also advised as healthcare workers, as community section workers, to make sure that all delivery practices reduces the chances of HIV exposure to the infant. Whatever we're doing, both cord cutting and everything, we must follow protocol to ensure minimal exposure to the virus. Remember, we said if the virus is undetectable level, that the chances is less than 5%. So telling you that still chance of transmitting the virus, the chances is less than 5%. Now, another thing is special considerations during labor and delivery. There is need for special consideration during labor and delivery. You as health worker, you should apply universal precautions, such as safe needle handling for the baby, safe needle handling and storage. You have to also put up your PPE, personal protective equipment, your face masks, your coverall, and all of that, your gloves. This should always be implemented in all the maternity wards for all patients, regardless of the HIV status. Then during labor, you are expected to conduct labor at the primary healthcare level using the pathograph. That's the standard. You have to monitor every labor, especially multigravidal. Most primates should be conducted by the medical doctor or medical officer. So you as choose are expected to actually attend to pregnancies using a pathograph. So you are expected to use pathograph to monitor progress of the labor as recommended for all delivery. You must. If there is prolonged labor, you should try as much as you can to refer. So it is important to prevent prolonged labor, especially in HIV-infected women, because if there is prolonged labor and the membrane covering the baby has already ruptured, the baby is exposed at higher risk of HIV infection as the baby stays more longer in utero. Another precaution you must take during labor is you have to limit the number of vaginal examinations you perform. You have to limit the number of vaginal examinations you perform. You have to. Because if there are lesions or wounds in the birth canal, it will increase the risk of transmission to the baby. So you have to limit the number of vaginal examinations you perform. Then limit the time. Then limit time between rupture of membrane and delivery. That's what we say. You should try as much as possible to avoid prolonged labors, because once the membrane has ruptured, the baby is exposed already. Note: for every additional hour following ruptured membrane, the risk of HIV transmission to infants is increased. The risk of HIV transmission to the infant is increased by 2%. So if the membrane ruptures is early, for every hour, the chances of HIV transmission to the baby is around 2%. So the longer it stays, the higher chances of the baby becoming infected with HIV. Then you as a health worker, if the mother goes into labor and the labor is progressing, you should avoid rupturing the membrane by yourself. If possible, deliver the baby with the membrane alongside. So please, as much as possible, avoid rupturing of the membrane artificially. Induced labor, according to protocols of the health care system in your country. Induced labor, according to protocol, especially when there is spontaneous rupture of membrane, that membrane have ruptured on its own, you have to induce the labor following protocols or proceed with cesarean section. Do not delay as the baby is being exposed. Avoid invasive procedures during delivery. You have to avoid invasive procedures. Example of invasive procedure we're talking about is vacuum extraction method of baby delivery. Using a vacuum extractor to deliver a baby, or using forceps method of delivery, or giving the mother episiotomy. Anything that will lead to bleeding or coming out of the mother and exposing that baby, you should avoid it in order to limit the risk of HIV transmission. However, if these measures are necessary to save the life of the mother or the infant, they can be performed. So this is where risk to benefit ratio comes into play. Now, the next is breastfeeding. We've looked at starting the drug. We've looked at what we do when in the labor ward to prevent HIV transmission. These are packages of PMTCT. Breastfeeding. Exclusive breastfeeding is recommended for the first 6 months of life if the mother is on effective antiretroviral therapy and has an undetectable viral load. That is why we keep on hammering on starting the drug as early as possible, so that during this high-risk period, the mother will have undetectable level of viral load. So that is where your counseling will be effective, because if you counsel them well, they are going to subscribe to the starting of the drug and going to maintain it. And then the job becomes much easier. If the mother's viral load is detectable, avoid breastfeeding and think of alternative method of feeding the baby, such as using of formulas, in order to eliminate the risk of transmission of the virus to the baby through breast milk. The next component of PMTCT is monitoring and follow-up. It is important to perform regular follow-up of both the mother and the infant in order to monitor their health outcome and adherence to the treatment, and also ongoing support. You have to clinically follow up these people, the mother and the child. HIV-exposed children should be followed up until HIV infection can be totally ruled out or confirmed negatively. That is, you have to carry out follow-up until they are about 18 to 24 months old. That is around 2 years. You have to follow up that baby until you perform the test and the test reads negative. That is around 2 years. During the first year, whenever they come for immunization, you have to review this baby, check the viral load, and all of that. It should be performed this way. From 6 weeks of old, when the baby from 6 weeks, that is a month and 2 weeks, to 6 months, every month the baby should be reviewed. Then after 6 months, then the baby should be reviewed every 3 months. Ensure this. It is encouraged that you see the mother and the infant together, or the baby rather together. If need be, if the partner and the other siblings are not yet tested, you can use that opportunity to text them. So these are the components of PMTCT that you're expected to know based on your level. Thank you very much. I was expecting your questions at the comment sections. A recap. We've looked at prevention of mother-to-child transmission, PMTCT. We looked at what it's all about, the impact, the things we are going to use to check the impact of PMTCT program, where we looked at percentage of HIV positive pregnant women receiving ART. We looked at another parameter is the rate of HIV transmission rate among infants. And another parameter is overall maternal health outcome of the mother. Then we looked at the 4 prongs. We looked at the 4 prongs of prevention of mother-to-child transmission of HIV, which is cornered or which is anchored on prevention, care, treatment, and support intervention. So PMCT is anchored on these 4: prevention, 1, care, 2, treatment, 3, and support interventions. Then we looked at components of prevention of HIV transmission. We looked at primary prevention of HIV infection among women of childbearing age. Then we looked at preventing unintended pregnancies among women living with HIV. Then we looked at preventing HIV transmission from a woman living with HIV to her infant. Then we looked at providing appropriate treatment, care, and support to mothers living with HIV and their children and family. We looked at this. Then we looked at key components of PMCT, where we looked at initiation of lifelong antiretrovirals, and we looked at the challenges. Then look at, before you start that initiation of the ART, you have to give pre-test information, because you have to test to confirm they are HIV positive. So the pre-test information, we looked at them. Then we will look at chances of HIV virus transfer to the child, if PMTCT is given and if PMTCT is not given. Then we looked at possible way to prevent a mother-to-child transmission of HIV. We looked at the texting procedure. We looked at the test results will remain confidential. Then we looked at that they can refuse and later accept maybe anytime they choose. But however, they should understand the effectiveness of PMT to unacceptable level, especially during the high period when we talk about pregnant, delivery, and breastfeeding period. Then we look at the information to be given, that's post-test counseling. If a person tests negative and all of that, well, we looked at that you have to explain the meaning of the negative results then. Where you're going to talk about the preventive strategies of HIV. Where you're going to discuss about risky behaviors and the need for protection during pregnancy and postpartum. Then you have to encourage the woman to return to take the test in 3 months before delivery. That is if the woman is negative. They also talked about you giving the woman condoms every time they come for A and C. Then if the woman has tested positive, looked at you providing emotional support to her and the meaning of the result, then counseling her that she can have a good chances of living healthy and even the baby not getting the virus, and even with the partner not getting the virus. You have to explain the risk of transmission to child if they do not subscribe to the PMCTC intervention. Then the importance of regular follow-up before and after birth. Then you also have to discuss with her the importance of texting other siblings and the partner. Then we looked at starting ART very early. Then we look at ART preparation and counseling section, things that are expected of you to do, performing of the test and starting of the treatment. Then we looked at the drugs used, the fixed dose combination of the novel, lamivudine, and dolutegravir, and the addition of a 50 dose of DTG if the mother is having tuberculosis. And also the possibility of switching to another drug if the renal creatinine clearance is poor, mostly done by physicians, and the importance of switching to other drugs. Then we looked at safe delivery practices in terms of, we looked at vaginal bed